Good evening. I want to thank all of you for joining us this evening. Were this an ordinary year or regular year, there'd be no way that Temple Micah could be hosting or having a program such as this, as many of you would be hosting Passover Seders tomorrow evening of 10, 20, 30 people or more. The kitchens would be busy. People would be screwing around, preparing all the different ritual elements and the food that is central to the Passover Seder. But this year, as we think about the classic Passover question, why is this night different than all other nights? Even the night before Passover is different than all other nights, because this night, even as we anticipate Passover, we are thinking about that which is outside our doors, and we're thinking about why we are staying home this evening and all evenings and all days, protecting ourselves from the virus that is currently plaguing the entire world. I'm so glad that we're able to offer this program for our Temple Micah community and beyond this evening. And I'd like to take a moment to simply introduce our panel. Our moderator this evening will be Dr. David Skorton, President and CEO of the Association of American Medical Colleges. This program, it was actually an idea that David brought to me just over a week ago, and we're able to put it together very, very quickly. The members of our panel, in no particular order, are, and all these people have long bios, and I could go into detail on all of them, but we want to have the time this evening for their presentations and for our Q&A at the end. Dr. Manya Magnus is a professor of epidemiology at the Milken Institute of Public Health at George Washington University. Dr. Richard Katz, who I'll say one more word about rather than his bio. I've known Richard for many years. We grew up together on the north side of Chicago, and I've known him since we were in high school, a dear longtime friend. Dr. Richard Katz is Chief Medical Officer at Mount Washington Pediatric Hospital and a Professor of Pediatrics at Johns Hopkins University Medical School. And Dr. Ross McKinney, who's the one member of our panel who is being truly generous, because he's not a member of the Micah community, but he was gracious enough to respond to the invitation of David Skorton, who he works closely with. Dr. Ross McKinney Jr., welcome to the Temple Micah community. We're so glad you're with us this evening. Dr. McKinney is Chief Scientific Officer of the Association of American Medical Colleges. I will turn the program over to David Skorton in just a moment. We'll begin with presentations. There'll be time for Q&A. And at the end of our program, we will conclude with a prayer that our talented worship music artist, Deborah Winter, will lead us in. I'm so glad to turn the evening over to Dr. David Skorton. Thank you all so much once again.
Thank you very much, Rabbi Zemel. It's a great privilege to be here tonight and to share part of an evening with our community. Well, as you said, Rabbi, this is a very different night, a very different week, a very different month, and a very different time in the life of each of us and our community. A lot of changes have occurred because of this pandemic. We've had changes in our immediate day-to-day routines. Many of us are working from home. Those who are fortunate that their jobs were not affected by this. Many of us have had changes in our feelings of well-being and safety. Many of us have had feelings of lack of confidence in certain systems, or at least doubts about those systems. And many of us have had changes in our way of looking at life in general. Could such a thing come almost apparently from nowhere, and in the course of just a few weeks, literally turn the world upside down? We've had a very rapid rise in cases all over the world and in deaths, including in this country, including in this very community that we're in right now. So what is our best defense against such a time of uncertainty? What is our best defense at such a time where we really feel unsettled, off balance, and uncertain of today, let alone tomorrow? Well, I firmly believe that the best defense we have is good, solid information about the microbe itself, about the syndrome, about the epidemiology. And thanks to the amazing community that we live in, it was very easy to pull together what I think you will find to be an authoritative group of presentations by an authoritative group of very generous people who are giving their time to share this knowledge. I believe that as we learn more about what we're going through, the facts and the figures and likely outcomes, at least for me, it's been a source of great settling and of great centeredness to have some good facts. So that's what this evening is all about. It's about sharing some information with you and then opening it up for whatever questions you would choose to ask us. So Rabbi, again, on behalf of the panel, I thank you for the great privilege of being able to share this information with the Temple Micah community and beyond. And we're going to start by me introducing again Dr. Ross McKinney, who will kick off our presentation tonight. Ross, thank you for joining this, and over to you.
I'm just going to jump in for 1 second, excuse me, just to remind our viewing audience that the questions you'll be able to ask will be by using the chat box on your YouTube screen. And those questions will go to Deborah Winter and the system will work. So type in your questions into the chat box. Excuse me, over to you, Dr. McKinney.
Okay, well, good evening, and I'm very glad to have the opportunity to speak with you, and I hope I can give you some information that's useful to you, because I agree with Dr. Skorton. Understanding what we're up against is a critical part of being able to feel more in control of what is a very out of control feeling time. So first of all, we're talking about the infection with coronavirus SARS-CoV-2. It produces the disease COVID-19. And SARS-CoV-2 is a coronavirus, and they're called coronaviruses because electron micrographs of them show a kind of a crown-like set of protuberances around the virus. And this is an electron micrograph of one of the respiratory coronaviruses. And they've been known for quite a while because there are 4 strains of coronavirus that produce the common cold. There's the SARS coronavirus that produced a very severe acute respiratory syndrome. And then the MERS Middle East respiratory syndrome virus, which is actually carried by camels. The way that the virus is put together matters because it's going to help us figure out how to develop a vaccine, and it tells us a lot about how it's spread. So this is an enveloped virus, which means it's got a lipid layer around an RNA core with little proteins sticking out of the virus. Those proteins attach to receptors that are on the cells that the virus can infect. And so it will attach and then it'll be engulfed, and then the RNA will be released into the cell where it will start a replication process. The lipid bilayer here really matters because for the virus to be infectious, the whole particle has to be intact. It has to have intact protein on the surface, it has to have intact RNA, and the lipid bilayer has to be intact. And these lipid bilayers fall apart quite easily with drying, with soap, and with alcohol, because they can be dissolved. So you look at something like, why does Purell work? Well, it works because it dissolves the envelope of the virus, it falls apart. It's also why this virus is primarily spread by droplets, which are small droplets of fluid that you expel when you cough, when you speak, when you sneeze, and the virus is carried in those droplets. And it needs to be in those droplets because it needs the water around it to keep that lipid bilayer together. When it starts to dry, this virus falls apart. So viruses are not free living. They require access to live cells in which to grow. An example of a dead cell, skin cells are dead. So if you get the virus on your skin, you would not be infected simply by having the virus on your skin. You have to convey it from your skin to your mouth, to your nose, to your eyes, to some other place where there are live cells on the surface. And those are all the mucous membranes. What mucus does is to provide a water layer so that cells can live on our body's surfaces and exchange things with the environment. So mucus allows us to have an exchanging membrane. Some viruses are stable in the environment, some are not. HIV always has to be surrounded by water, so the only way HIV is spread is by contact or by some form of a moist environment getting to another moist environment, where measles, in contrast, wafts happily in the air. Those particles are quite stable. And so measles can infect people yards and yards and yards away from the infected person. So the most contagious form of virus would be an aerosol. And we think that for coronavirus, aerosols are not a big part of how it's spread. It would be for measles, but it's not for coronavirus. However, when there are procedures done, like with a bronchoscopy, you will generate aerosols, small particles that can waft. And there is discussion back and forth about whether there is any aerosol spread of the coronavirus. But at this point, the belief is that the primary means of spread is droplets. And a classic droplet spread virus would be influenza. You can also have viruses that are spread by contact, viruses that are spread by a fecal oral route, and then you can also get viruses on surfaces. That's called fomites. And the classic fomite would be a block that is handled from one kid to another in a daycare. First kid licks it, second kid licks it, spreads viruses, spreads whatever. For most of us, fomites are not as critical as the droplets. So this is what the reason for social distancing. That the droplets that are generated by our coughs and our sneezes are typically of a size that will fall within 3 to 5 feet. So that the transmissibility is generally limited by how far the droplets will go. And obviously the further they go, the closer they are to the floor. As opposed to something like an aerosol, which can spread much farther. So that's why we have that 3 to 6 foot limit to keep people away, because that's the range in which you could actually get caught by a droplet expelled by an individual who's infected with coronavirus. There also have been demonstrations that you can generate aerosols. There was an article in the New England Journal of Medicine just a few weeks ago that showed that aerosols could be generated using a nebulizer, like you'd use for an asthma treatment, and that when that was done, the virus remained viable, could be grown out of the aerosols for as long as 3 hours. However, those were very precisely nebulized aerosols, not the kind of thing you get out of a person. It can also remain alive for 4 hours on copper, for 24 hours on cardboard, for 72 hours on stainless steel or on plastic. And when I say alive, it just means if you were to scrape it and put it onto a culture system where you could grow virus, you would be able to grow it from off those surfaces if you scraped it for as long as 72 hours. Now, where did it come from? It is probably a bat virus. And most of the coronaviruses started probably as bat viruses and then came through an intermediate host. The SARS went through something called the palm civet. That's a kind of cat. The MERS went through camels. And we think that the SARS-CoV-2 probably went through pangolins. And I put this picture here up mostly because I think pangolins are really cute. And I wanted to have an excuse to put a pangolin picture up. Here's what the clinical picture looks like. The key thing is to think about, as I tell you about the story, I'm going to start at time 0 where the infection occurs, where somebody is exposed to somebody who is infected. They get it onto their mucosal surfaces, and as a result, the virus begins its infectious process. They may have gotten it from a droplet. They may have gotten it by a handshake. They may have gotten it from a fomite, but in some way it hit a mucosal surface, eye, nose, mouth. There's an incubation period of several days where you could not detect the coronavirus in the person if you tried. It's there, but it's in such low levels that it can't be detected by our PCR technologies. And polymerase chain reaction is the method that we use to find the viral RNA in people and in other environments. Next, we switch at about day 3. The typical case, and this is about day 3, it varies considerably, but about day 3, the person becomes contagious. They become PCR positive. However, they have a period of several days where they are contagious, but they are not symptomatic. And the question then is, what happens with people who are in that phase? What do they usually do? And our best sense is that most of the patients who are infected but have no symptoms, who are in this early phase, eventually develop symptoms. We don't know the exact percentage. In a Seattle nursing home where they were doing studies looking with PCR at contacts of people who were infected, they found 13 individuals who were PCR positive. Of those 13, 10 went on to develop symptoms. When the WHO went to China and looked at all the Chinese studies and analyzed them, it was said that it was very rare for somebody who was PCR positive to remain without symptoms. Most people who get infected eventually develop symptoms. So you can go for 3 to 5 days spreading it without symptoms, but most people eventually get symptoms. Around day 5, it may be as late as day 14, but around day 5, typically, you get the onset of symptoms. They're typically mild. The person at that point will still be PCR positive, and they're maximally contagious at that point with the early symptom phase. And those mild symptoms, about 80% of people stay in some form of mild symptoms. And I'll go through what the symptoms are shortly. But about 80% of people don't go beyond mild to moderate symptoms. They may feel quite sick. They may feel like they've got the flu. They may have headache and fever, but they're not so sick that they need to be hospitalized. What typically happens in coronavirus is about day 10, people sort of declare somewhere between 8 to 9 days after symptom onset and 10 days after being infected, somewhere in that range of about 10 days, people declare if they're going to get better or they're going to get worse. And they have what is sort of a crisis. And when they do that, if they have the symptoms that require admission, which are typically, again, persistent fever, air hunger, severe cough, lots of myalgias and headache, those people may be admitted, particularly with air hunger and decreasing oxygen transfer. They may be admitted to the hospital. Of people who get admitted to the hospital, about 2/3 don't require intensive care unit care. They just require oxygen and fluid support because they may not be able to eat or drink. They have an acute respiratory distress syndrome, and they have a pneumonia. About 20 to 30% of people who get admitted to the hospital end up going to the intensive care unit. The average time of death for somebody, if they die of coronavirus, is about 3 weeks after the infections, the moment of infection. So it's a long process. And usually what they die of is a combination of oxygen deprivation or cardiomyopathy, an arrhythmia of the heart. And about 1 to 8% of patients die. It can be as high as 15% of people who are over the age of 75 when they get infected. So for symptomatic patients, these are the symptoms: fever, cough, muscle aches, tiredness, shortness of breath, which begins sometimes even at the beginning of the illness in 31% of people, sore throat, headache, hemoptysis, which means coughing up blood, and diarrhea. So basically, it looks an awful lot like a really bad case of influenza A, which has also been circulating but is starting to fade in the community. For treatments, there are several drugs under evaluation, none that are approved. Kaletra, which is an antiretroviral drug that's used to treat AIDS, didn't prove to be effective in its first Chinese study. Remdesivir is the drug in which people have the most hope. It's a Gilead Sciences drug, an adenosine nucleotide analog. It has to be given by IV. It probably works most effectively if given early. There are clinical trials ongoing. If somebody is infected, one would hope you're at a site where you might be able to get into one of the remdesivir studies. There also has been discussion about chloroquine and hydroxychloroquine, which are malaria drugs. There is no evidence that they have any particular benefit. There was one controlled study done in Japan, 64 patients. Patients who got chloroquine got better 1 day sooner than patients who did not. All of the patients were mild, and the change was just barely measurable. There's also favipiravir, which is a Japanese anti-influenza drug that's in study, but doesn't have a whole lot of promise. The other area that people are looking at is to modulate the immune system, to dial down the immune system for people who are having the respiratory distress syndrome, to take care of those symptoms. And actually, some of those studies look promising in animal models. There's no coronavirus vaccine yet. The fastest way to develop a vaccine is probably going to be using virus-derived DNA. Those studies are underway. The optimistic view would be that in 18 months or a year at best, we will get a vaccine, but it's going to be a slow process, and that has a big effect on what the epidemiology is that Dr. Magnus will be discussing. Here is the epidemiology of coronaviruses. It's my concern. So if you look at this, I hope the mouse shows up. You get a peak in January through about May in the respiratory coronaviruses every year. So these are the kin of the SARS-CoV-2, and they produce a cold, and they occur primarily in winter, and in the summer they go away. So some of what we're seeing now may in fact be the typical abatement of coronavirus in the community that happens about this time of year. The worry is that this will come back in the fall, and that's what happened with Spanish flu. In 1918, this is mortality in England. There was a minor blip. There was significant mortality. People got very worked up over it in the spring, but in the fall, they really got the very lethal, highly memorable Spanish flu epidemic. And then actually there was another wave in the spring. So we hope this does not occur with coronavirus. So my last closing words, if we get lucky and the outbreak abates with summer, which we hope, we better be prepared for the fall. At the moment, it looks like we're going to see regional decreases. Some places get better faster than others. Some had more to start. Some had better spacing. Spacing works. And after we get done with the current epidemic, and we'll hear about this from Dr. Magnus, we don't know whether it's going to become endemic, which means persisting in the community at a low level, whether it's going to be seasonal, or whether we'll be able to control it with a vaccine. And at that, I'm not going to have questions now. We'll have the questions later, and I'll hand it over to Dr. Magnus.
Dr. McKinney. Good evening. Thank you so much for including me in this important panel, and greetings to my Temple Micah family. I'm glad we can connect here online. And thank you to Dr. Skorton, Rabbi Zemmel, and Dr. Katz and Dr. McKinney for including me in this important panel. Today I'm going to talk about, sorry, I have nothing to disclose. And also I just want to point out this is for educational purposes only, and you should be sure to speak with your physician in the event you have any questions about your care. So I really want to highlight how much data is out there. For people like me, this is extremely exciting, but for most people, it's also very overwhelming. So the purpose of this next 10 minutes is to talk about the data and give you some clues about how you at home can sort through it without it becoming overwhelming to you, how you can make best use of it for yourself, for your family, and to understand where we are in the global pandemic. So I'm sure many of you have seen slides like this or like this. You've seen these slides, you've seen maps, and it's really important to remember that these all tell us something, but they can also be overwhelming. So we want to talk about exactly what they mean and how you can look at them. We're going to come to that throughout this session. But before we do that, I want to tell you what epidemiology, because I will tell you, many people think that epidemiology is the study of skin. But in fact, the epidemiology is actually not dermatology, but it's the study of the distribution and determinants of health-related states or events in populations, and the application of this study to control these states or events. And what I like about this definition, and as an epidemiologist, we're very keen on definitions, is that it talks about the distribution of disease in populations and also what else we can do about them. So not only describing, but how we can leverage this information, all the data that you have to help us understand better what is going on. We consider ourselves the foundational science of public health, along with our cousins, the biostatisticians. And there are numerous epidemiologic methods that we use here in the COVID-19 response, such as mapping, modeling, quantitative description, that's using numbers. testing what we would have found by chance alone versus what we've actually seen, how our models stand up to that chance comparison. And then of course, the methodology behind the clinical trials of potential vaccines and treatments that are really critical, as Dr. McKinney referenced, to understanding what will work to help protect us in the future. So in the next 10 minutes, I'm going to hopefully demystify some of this and make it a little less overwhelming for you at home. So I want to point out that these slides I showed at first, we're really looking at some of the same data in numerous ways, but this can become mind-boggling. You can look at this scale, and I'm going to give you a couple of hints about how you can sort it out when you look at it. You see where the arrow is right here. This will tell you what this is our y-axis, and this tells you what we're counting over here. And this axis is time since a certain point. And in this point, it's the days since 20 cases, but sometimes it's 100 cases or whatever the person is measuring. And this is called a linear scale. Now, it's important to see this is very hard to tell what's going on down here. So what we tend to look at when we think about COVID-19 and other types of epidemic situations is a log scale. Now, this is circulating around, and I just love this comic because obviously most of us didn't pay enough attention to exponential functions when we were little. So here we are, we can actually use them, which is nice, and we can transform our data looking at a log scale. And all this means is that here are confirmed cases. We're looking at a different y-axis, same numbers. And what this essentially does is it squishes down our scale. So in one glance, we can look at the low end and the high end at the same time. And the beauty of this type of log scale is in fact that you can see here a natural curve that mimics our exponential function emerging. And it helps us to understand the data in a much clearer type of way. Now you can also look at things that are normalized by population. Now this is my particular favorite way to look at the data, same data as the previous two slides. This is my favorite because it normalizes by the population while still looking at a log scale. And here we're looking at the cases per 1 million people. Now this is important because what you can see here, here's District of Columbia highlighted. Here's New York up here. It's a little dim, but it's intentional is to be highlighting DC. But you can see here, for example, Louisiana, which has a much smaller population. So the absolute number of cases is expected to be lower than you would see, but it's got a higher rate per person count normalized by population, so per 1 million people. So I think it's important to look at this because it tells us about population size, not just about absolute numbers. So the sheer volume of data, though, that are coming out of the news, the newspaper, the Washington Post, the New York Times, every single person has their own model, and it can be kind of mind-boggling. And so it's important to notice what is the source of data for each model, each website. And sometimes it can be clarifying if you're curious about what's going on to look at the data source. Is it surveillance data? Is it a hospital-based data? Is it made-up data that's just looking at a potential statistical model that's not even based on expected or actual counts? It's also confusing when we have changing predictions, and every day you come to a different prediction, and then it's hard to figure out exactly. You can think about these models as tools, epidemiologic tools, to help you to know how to protect your family's health. How do you protect your, how do you protect your family's health? And then also figuring out what we can do and when we can think about the best public health interventions that are pharmaceutical or potentially non-pharmaceutical. Here we have now. So I'm going to start here with this particular model. There's a number of models going out there. This one has been particularly confusing, and I keep hearing a number of very deep questions about this model that reveal that people are misunderstanding this model in particular. The citations are on the bottom if you're interested in checking them out. But it's really important to notice here that this model is not number of cases. This is looking at the health care utilization that will be needed to treat anticipated cases. So I want to point that out. I'm going to focus in a little bit on that. Also, you can see here, we're going to drill down to that from. What the peak means is per day, whatever you're looking at, whatever paper or website, it's important, which is an uncertainty level. And if you look here more closely, you can see in the parentheses, it's a confidence interval. And that means that in their model, where they took numerous statistical repetitions of a model, they select from them and they come up with a range. This range is important because this range tells us that the real answer could fall most of the time within the range of, for example, here, 123,000 and 417,000. Now, this particular real estimate may or may not fall in that, but it's important to know that it could be as low as the lower bound and as high as a higher bound. Now, again, this is not cases or deaths, but this is all the beds needed on that particular day. And that's important to know what that looks at. Now, I'm going to talk about for just a moment what goes into those models so they're not a mystery. They're characteristics of the epidemiologic curve. There's an example of the curve you can see at your below right. That's an epi curve, which helps us as epidemiologists track an outbreak. And so you can see when they occur. It takes into account usually population structures, such as how much of the population is of a certain age, because we know that there's differential rates of sickness and dying and hospitalization among different ages. It takes into account healthcare utilization resources, how many beds and ventilators there are, reported population death rates. It takes into account large-scale government declarations, such as closure of schools and travel restrictions, stay-at-home orders, and it takes in other parameters. So these are very complicated models, but if you can know a little bit about what's in each one, it can help you be a little bit less nervous about it. This right here is the formula that drives the statistical model, but you don't have to worry about that, at least not till your next lecture. Now, one thing you might want to know is the reproductive number. People talk about this a lot. The R naught is one of the favorite epi terms. It yields a lot of confusion. R naught represents the number of new cases each infectious person can cause on average. But it's important to note that this is a changeable, not fixed estimate. And here you have on the right, you can see different R naughts for different diseases. And it's really important to know we have here an uncertainty range. Our uncertainty range is, again, a confidence interval. So we expect that most of the time, the true R naught will fall somewhere between 1.5 and 3.5, and we think is about 2.6, but that can really change. And it helps us to parameterize our models to figure out exactly what those models should look like. But it's important also to know that those R naughts are not fixed. They'll change with intervention. So every time you wash your hands and every time you disrupt the membrane on the coronavirus, every time you stay 6 feet apart and every time you don't go out, those change R naught on the population level. And that can, again, change our models. So I'd like to point out that with this new pandemic, many parameters of the models are unknown. So part of the frustration I sense when I talk to different groups of people, including my students and people, my neighbors, people in the community, is that it's really frustrating that we don't know much and that the knowledge keeps changing and we have to keep incorporating that. And that's hard because we don't know enough and things do change. And we might be recommended to wear masks one day or not wear masks one day and then wear masks another day. But that's partially because we are having knowledge emerge. So it's a good thing, even though it can be confusing at times. When you're looking at those predictive models, it's also important to note that you might be looking at models that differ. So you have to be very careful about what you're assuming the model means. Does the model look at death, ICU, bed utilization, cases, and so forth? But I want to drill down in the last couple of minutes to why there are so many uncertainties. One primary reason is because of testing. And the testing issue really impacts our models. The tests only represent a small fraction of those who are positive for the novel coronavirus. And you can see here a pyramid where you can see that the top little triangle indicates people who tested positive and died. Now, that is already a troubling characteristic because we don't know if there are other deaths that are not attributed to COVID-19 that in fact might be the cause. So that's a troubling estimate and it introduces uncertainty into our models. Then you have people who are tested, infected. You have people who are tested, infected, treated at home. But then underneath this iceberg, as we like to call it in epidemiology, you have all those people who are not tested, who are mildly symptomatic. And then you have people who are not tested or maybe asymptomatic or possibly pre-symptomatic. So a lot of what goes into our models may not end up being exact because of the testing delays that we have seen. Tests, in addition, that are new are not perfect. We don't use them widely enough, but even when we do, it's important to note that they may not be perfect. We have reagent changes. We have ways of testing better than we did even 2 weeks ago. We have the characteristics of the test itself, which could include false positives or false negatives. We don't know what these things can render in terms of thinking about our models or in terms of thinking about our community. So it's important to remember, again, that this is a very dynamic situation, and we really are emerging very, very quickly with knowledge, but in fact, we aren't perfect yet. So being mindful about that, and some of the confusions may actually be a result of some of these early testing challenges. And antibody testing, which will tell us whether people have been exposed to the virus, and that has just been approved. That will really help sort things out. But again, we don't know everything about this durability of immunity. So what we're going to have to find out over time is how long the immunity will last. And so we can't take a lot of chances even once we have antibody testing. So I want to look back very briefly at our DC models here for this IMHE model again. And you can see here, just to make sure you're with me here, you can see the models. You can see our peak day is, by this model, expected to be around April 15th, tax day, or previously tax day. And you can see the number of beds available and so forth. So that's an important thing. And you can see the upper and lower bounds. And I want to point out that the mayor presented a lot of other important data the other day. And in fact, she presented a slide which contrasted different models, the CHIME model out of University of Pennsylvania with the University of Washington IHME model, and it looks at different utilization needs. And I just want you to point this out because this can, hopefully now, won't be so upsetting to see these differences, but you can use these for information to think about planning, and we can recognize that these are planning estimates, but they aren't certainties, and we have to take them all into account to try to prepare as best we can. What do these models do then if they're never matching and they're so contrasting sometimes? I think they help buy us time. If we're successful in flattening the curve through these non-pharmaceutical approaches, and maybe eventually pharmaceutical approaches, we'll reap a lot of benefits. We'll stretch resources. We'll use those models to help us identify resource allocation and prepare for every type of eventuality. It will give us time as we flatten the curve to develop treatments and test them, noting that data from clinical trials are critical. We cannot use anecdotal reports or observational studies to ensure safety or efficacy of any vaccine or treatment. And then it also can help share resources around the country. And maybe together with our efforts, we can move from the top part of our uncertainty range to the bottom. For those data people who are just fascinated with these data, as I am, you can also see that data can be used to assess the impact of stay-at-home orders. Here you can see the United States has a D rating looking at cell phone data, A- for District of Columbia, yay. But you can see here that just looking at all people with their cell phones, you can see in the different ratings of when people actually have been staying at home. You can look at smart temperature taking, which is a type of a company that has smart thermometers. And you can see different temperature pockets here, which may or may not be related to COVID, but could be in fact useful. And then in China, they did a really interesting study where they looked at migration patterns. And they could see, if you look on the rightmost graph, you could see that with the increased stay-at-home orders, they were actually able to press the case counts lower in that last box right here. So data are helpful. They can be confusing, but they can also help us answer questions and see if we're doing the right things. So in the end, all of these things, you've probably seen this graphic, are here to help us flatten the curve, to buy time so that we can get those other types of resources available to ourselves and to our community, and also ensure that we have clinical trials available. So why can we feel lucky? In my last two slides, it's really amazing to see this remarkable science. We've had incredible investments from other diseases. I work in HIV, so seeing some of the molecular epi come to the fore here is remarkable. In the immunology, there's an incredible amount of science in play that's coming to bear here. It's mild most of the time. The transfer of information has been open and honest by and large, and it's really amazing that we've gotten the genome characterization so quickly that we could develop testing within the last couple of months. We have best practices being shared globally and knowledge sharing. We have states that are responsive to public health urgency, with governors really stepping up to make sure that we do the right thing. And the clinical trials research is faster than ever. There are trials in progress for vaccines and for treatments already, which is really unprecedented. And in my own little world, I think it's great to inspire the next generation of scientists and epidemiologists, because finally people know what epidemiologists do. And so please, if your kids have questions and you want to get them in the public health world, please call me up and I'm happy to talk with them and inspire them about the world of epidemiology. So last slide, what can we do? Pay attention to communities at greatest risk. We are very lucky, most of us, that we have jobs, we have safety. This is an inconvenience, but it's not a life-destroying situation. This is hitting minority communities disproportionately. People who are vulnerable already have too little safety net, and we have to look out for them and make sure that they are counted and helped. We should continue social distancing. We need to understand why there are rapid changes so we can be responsive to those. We need to elect leaders and political representatives who value science and public health, and listen to the scientists and physicians. Don't try to take things into your own hands. We have a long road to go ahead, and it will really continue. It takes continued personal and political will if we really want to slow this pandemic. This won't be the first pandemic. It's not the first one, and it won't be the last one. So please think about what we can do next time so that we don't make some of the mistakes we've made today. So thank you again for having me. And it's really a delight to see you all in here in our virtual space. And I turn it back to you. Thank you.
Thank you so much. And now we're going to turn it over to Dr. Richard Katz. We'll give the last formal presentation, then we'll open it up to a variety of questions. And by the way, fellow panelists, we have a bunch of great questions in the chat already. So Dr. Katz, Richard, over to you.
Thank you very much, Dr. Skorton. As you know, I'm a chief medical officer of a pediatric hospital. It's Mount Washington Pediatric Hospital, which is jointly owned by the University of Maryland and Johns Hopkins Hospital, although I'm a full-time Johns Hopkins faculty member. So that's given me the opportunity to interact with the leaders of both the University of Maryland medical system and the Johns Hopkins medical systems, and to know that there are many similarities, to know what these giant hospital systems are doing to help prepare their hospitals for treating and diagnosing COVID, but also to know that there are differences. So as I finally said, I say many times in the lectures I give to medical students, there's never just one right answer. And I think this kind of disease process is really proving that there are many ways to tackle the same thing. Just a bit of history. So Mount Washington Pediatric Hospital was started in 1922 by the person who discovered that the great influenza, I'm going to do a lot of show and tell tonight, by the way, the great influenza of 1918, 1919 was not caused by a bacteria. This was Dr. William Welch, who was actually in this position that I'm in over 100 years ago. And he was the one who determined that it was a non-bacterial particle. Of course, he didn't have the ability to have electron microscopy at the time. And so we now have learned that it's a virus. And so the question comes up when I remind the people on my staff what this is all about. I ask, are we any better off than we were 100 years ago? And in some ways we are, in some ways we're not. We do not have a vaccine for this. We don't have a good therapy for it. There's lots of speculation about what might work, but nothing has been proven. So we're not any better in that regard. How are we better? That we're able to deal with the complications of the disease process. So now we have very, very good methods of delivering oxygen. There's simple oxygen methods. There's high flow oxygen that can be delivered. But we also have ventilators. And unfortunately, some people have to go on what's called ECMO, which is the heart-lung bypass, in order to have them survive. And of course, no one wants to imagine that for any of us. And there's just, as you talk about that with people, and I talk about this with the staff throughout the hospital all the time, it just evokes a tremendous amount of anxiety. And I think the biggest thing that we have to fear as hospital providers is the fear that everyone else has. And it's paralyzed some people. There are some people who do not want to come to work. There are people who don't want to come to the hospital for care, who need to come to the hospital for care because they're so afraid of it. But you know, as you've heard, there are the vast majority of people who get this disease do not get significant symptoms, don't need hospitalization, and very few pass away. However, very few is a false sense of security, because one death is more than one should expect. So what's happening locally? We now know, excuse me, that right now in some of the hospitals that Johns Hopkins has in the DC area, there are 5 patients with COVID in Sibley Hospital and 45 in suburban. Howard County has 10. Johns Hopkins total system has 200 patients. So this is out of a group of well over 6 to 7 million people. So it's still a relatively small amount. There are 4,300 cases in the state of Maryland and 103 deaths. that's a significant number of deaths. That's a significant number of cases. No matter how one looks at it, no matter what people say that we've been able to flatten the curve, we are trying to flatten the curve. We have not flattened the curve. And even when we do try to flatten the curve, there'll still be a large number of people who are infected. And not only are they infected, but because so many of them are asymptomatic early on, the likelihood is that they'll infect other people, including their family members. So, ordinarily, if I were giving a presentation like this for people to see me, I'd be wearing a three-piece suit, a tie, cufflinks, everything else. But I'm in scrubs because we all have this concern that no matter what, we could be taking this virus home. We don't want it ourselves. We don't want to transmit it to our patients, and certainly we don't want to take it home. So most of my colleagues now take scrubs, and the second they get in the house, don't wear them at all. And so it's just a process that everyone has had to adapt to. Most people have done well, but there are some people who have significant fear. And so, what we've learned over the last several weeks is that, we don't know what we don't know, and we only know a little bit of what we know. And I have learned over the many years I've been doing this. In fact, I once gave a lecture to medical students about the 25 ways to say, I don't know, without sounding stupid. And, right now, as I talk to all of my staff, I can say, I don't know all the time, but I don't know because there just isn't good science for that. And, unlike some politicians, we in the medical field have to depend on good science. And, when we have good science, I think we'll be better able to find a cure and a treatment. But in the meantime, we're doing very simple things to try to protect ourselves. And so I have a little show and tell because I realize that people don't know what some of the protective mechanisms are. Obviously, hand washing is number one. The second thing is don't touch your T-zone. We say this all the time in the hospital. The T-zone is your eyes, your nose, and your mouth. Stay away from that as much as you can. And every time somebody will say that to us in the hospital, my first instinct is go, oh, what? And, so we really we want people to stay away from that. But what we've done now is develop a whole series of protective devices that some of you will be wearing on the street. So there are homemade masks. This one's a lovely pattern. And this one has ties to go around your neck. And the key is to wear this over your nose and your mouth. And I'm not going to waste these because everything is very precious. These are also homemade varieties that slip over your ears. Again, these are cloth masks. They do not prevent COVID. The particles are too small and they will get their way through these cotton materials. But what they will do is prevent droplets. So if you're in a conversation with someone and you're speaking very aggressively, you will spray things from your mouth. Or if you sneeze, you will, as you saw from the diagram, the bacteria and viruses will spread. And that's what these are for, to prevent that. If you're a hospital worker, we have these paper surgical masks. These are worn in surgery. We've now adapted them to everyone who has any patient contact in the hospital. In our hospital, they wear them. The University of Maryland and Johns Hopkins now have both moved to that. Other systems have done it earlier. Other systems are not doing it at all. And why wouldn't we do it is the big question. And the reason is there aren't enough of them. I will say that we have been woefully underprepared as a country as far as being able to get supplies. We've all been taught in the hospital world that there's a national strategic stockpile, that if something bad happens, the big trucks will roll out. Well, we're not seeing the big trucks, and we're short on equipment. We're short on ventilators, we're short on respiratory devices, and we're working on that. We're short of hospital beds. The device that many people hear about on the news and don't really know what it is are N95 respirators. And this one is from 3M, which has just now been contracted by the federal government. This was used for paint sprayers. So normally we would get these from routine medical suppliers. They're not available. So we're getting them from any source that we can. And we're also looking for donations. The other very sad part of this, of course, is that there are people who are unscrupulous. For those of us who are physicians who take an oath to care for patients, we're the only ones taking that oath, who've taken that oath. There are other people who are trying to make a fair amount of money off of this. And because of it, I've developed some new friends in the Department of Justice as we found people who've been trying to either commit fraud by selling us products that don't work or that don't exist or overcharging us. So it's a significant problem. I just have a few more things to demonstrate. What we've also asked our staff to do, since we don't have the N95 masks, is to wear this plus a plastic face shield. Now, this is the cheapest material you can think of. This is just plastic, vinyl, a foam backing, and an elastic band. Well, these are in short supply as well. So Johns Hopkins, because they have hundreds of medical students who aren't working or in class, they've put these all together. They've gotten a lot of people to volunteer to put these together, and this is probably the most productive thing most medical students will do in their entire career. And then we also have, can't open the box, I've been promised I can't open the box, our surgical masks with shields in front of their eyes, so that if you're taking care of a patient who may have a spray, they'll be protected. And then finally, this is called a PAPR. This is a powered air purifying respirator that goes over your head and is connected to a huge battery pack and ventilator. And you wear this, it's very heavy, but you have to wear this anytime you are in contact with someone who's COVID positive. So, as a pediatrician, can you imagine what it would be like to walk into a room with a bunch of young children and you'll need to do this? It would be scary enough as an adult to see that you're the patient, and that's what people have to do. And since nowadays people are in their ICUs alone, they are alone because they don't have visitors. So there's no one to share this with. So, the anxiety of this is tremendous on an individual basis, on a hospital basis, and on a societal basis. So, what we're hoping for those of us, on the front lines. I'm not quite on the front lines. There's a Jewish part of me that feels guilty about not being on the front lines and not being in the ER. And then there's this part of being a husband and a parent that I'm glad I'm not in the ER taking care of it, but we're all at risk. And so, what we can only hope for is that people will stay apart from each other, maintain social distancing, wash their hands, and truly help flatten the curve. And that's one of the biggest things that will help us. And I think, people ask me all the time, what can we do? Well, yeah, I would do that. I would, wear masks when you need to. Some people are very talented at making masks, and hospitals are accepting those voluntary donations because we have often no choice. And stay at home if you don't have anywhere to go. So, being on the beach with a bunch of kids or a bunch of college kids playing lacrosse in the field is not helpful. So we really want people to try to stay home. And then finally, I want to talk about two more things, and that one is children and what their manifestations of what COVID would look like. Right now, as you know, children are about 20 to 25% of the population in the United States. It varies from country to country. And so far, only 2% of the affected COVID patients are children. So for reasons probably because of a very active immune system that young children have, except if you're under a year, they're not getting the disease as often or as severe. So there may be a lot of children walking around who are vectors for this disease, meaning somebody who's got the disease, asymptomatic and transmitting it. And they also tend to get milder disease. And so what we've learned in the last several weeks is that some of these children, and this will scare parents, some of the children's early manifestations are runny nose, low-grade fever, and not just the high fevers, the dry cough, the shortness of breath. That doesn't seem to happen as often in children. So we have to have a little higher level of index of suspicion in children who might have something else. And then it's also very difficult, obviously, to see many pediatricians and internists and other practitioners have closed their offices or made it even more difficult to get in to see them. But, you have to be persistent. You just have to be persistent. So, what I would say is what's been said already, believe the science, believe that, everyone is trying as hard as they can. Don't believe the charlatans. There are people online trying to sell all kinds of things. There are people at press conferences trying to sell all kinds of things, but really, it's the science that will save us and keep us alive for the summer. Hopefully that's the time when this will end. So thank you again for allowing me to participate and for allowing me still be one of Danny's friends.
Well, thanks very much. I want to thank all the panelists for giving us just fabulous presentations. And we have tons and tons of great questions. Before I dip into those questions and pass the tough ones off to the panelists and take the easy ones myself, I just want to say one of the conclusions that I've come to over these last weeks is that the biggest mistake we can make throughout this pandemic is if we don't realize what has to be changed as we prepare for the next thing like this that will come down the line. Some things related to the way we look at the world ourselves, I believe. Many things related to how our government looks at things. Some things related to how we spend our tax dollars and where they go. And I think as we go through the questions, you'll see some of that same kind of concern reflected. Now, I'm going to read these questions from the chat box because we don't have a mechanism for our colleagues and friends to actually ask them in their own voices. Because I don't know whether people want to be identified or not, I'm not going to mention who asked the question. I'm going to take them out of order so I can try to cast them in themes. Now, the first one, very, very interesting and provocative question. Any chance this type of presentation can be made to our decision makers at top levels of the federal government? Would it do any good? Not wanting my panelist colleagues to get in trouble, I'll take a crack at answering this one. One of the very good news things about this that you've gotten a taste of is that people like the panelists, people who know what they're talking about, are steeped in science, based in science, are actually at the table sharing a lot of this information. And not only our organization, the Association of American Medical Colleges, and not only these wonderful academic institutions represented here, but many, many institutions around the country are at the table. And it's a rare day, I'm going to say this carefully, it's a rare day that one of us is not talking to someone very highly placed in one of the executive agencies of the federal government. But we have to make up for some lost time, and we have to hope that as soon as this pandemic begins to subside, and it will, that we don't forget about it and figure, well, this isn't going to happen again. It's like a 100-year storm. This will happen again. I'm not an expert in viruses or epidemiology, but even I can tell you as a cardiologist that something like this will happen again. And the preparedness in the country needs to be way better than it is right now. But I do want to answer the question by saying that there is a lot of input at the highest levels, right up to the White House, and we're trying to get the word through. So that's a very important question. Now, I want to see if I can toss this one to Dr. McKinney. Why was the testing method in South Korea so much more effective than ours in terms of suppression of the virus? Dr. McKinney?
Yeah, the reason was they were able to get their PCR tests up and running through a sequence that was a tragic comedy of errors. The CDC thought they had prepared a PCR test that could be sent out to state health departments and other laboratories. But in fact, what they sent out was flawed. It didn't work. And the FDA continued to use its traditional means of blocking. Actually, because we had declared an emergency, it made it so that the labs couldn't do what they normally do, which is just called lab developed tests, where academic labs develop tests. Well, they were blocked from using those lab developed tests. And the CDC couldn't get their test, which was approved or authorized, to work. So we ended up with no good testing system. And what the CDC would do is say, give us a preliminary result, send us a sample, we'll run it again. And so everything was very delayed. So we had like a few thousand people when Korea was into the hundreds of thousands of people tested. And the result was we had many people wandering around who were infected, did not know it, were infecting others. And because we had no testing, the wave began. And we are still suffering from the effect of that initial wave that we didn't catch because we didn't know who was infected and how widely disseminated that infection was. So yes, it would have been much better if we could have done more testing and found people who were less symptomatic and not just, even now, we only get the most symptomatic individuals.
Thank you, Dr. McKinney. And I might just add briefly that, like everything else in our wonderful country, it's a crazy quilt of some responsibilities for the federal government, some responsibilities for state government, some responsibilities for municipal government, some responsibilities at the very top of the public health pyramid at the CDC, many responsibilities for local public health departments. And one of the areas that we have underinvested in is the public health system in our country. We've underinvested in the CDC. We've underinvested in local public health departments. But thank you for that answer. Now, staying with the issue of trying to figure out what's actually happening before we talk about what to do about it, one of our colleagues asks, one of our friends asks, what do you think of the potential benefits or pitfalls of using personal mobility data, such as data from cell phones or Google location history, to help with the pandemic? Dr. Magnus, could you comment on that, please?
Sure, that's a terrific question. So I just want to clarify, those actually aren't my particular data that I showed up there, just to be clear that those were actually from another source. I have a lot of, usually I have quite a lot of concerns about that type of thing, but in this type of situation, they are an incredible adjunct to our understanding what's going on. I actually think that most of the provisions are in place to ensure security, but that should be something everyone's mindful of, that we really are careful about what data sources, how they're used. But those particular ones I showed actually are blinded and they're used in the aggregate, and the cell phone data that exists, they're basically leveraging them for public health good. So I think overall, it's a very important adjunct to our understanding how people are traveling. Are our stay-at-home orders working? And you could make a case that some places are way better than others. And that can help us have local interventions. So you could see a case where cities might be told, okay, you're not doing a very good job. Let's get you to an A level in social distancing to ensure that your local township or city is not having a worse epidemic or outbreak. So I think there are issues for sure, but I think that we can also use these things for good in new ways. And I think we have to think outside of the box when we have outside of the box problems.
Thank you. Thank you very much, Dr. Magnus. Another one for Dr. McKinney. One of our friends asks, what is happening in the Southern Hemisphere where it is autumn and not spring now? Because we've heard about how things might change, Dr. McKinney, with the weather.
Well, and it's not just weather, it's actually the season. So there are lots of things. It's people being indoors, it might be humidity, it might be, we don't really know. So what we're just beginning to pick up signal in places like Africa. And New Zealand has pretty much quashed it. So we don't know yet what the epidemic looks like or will look like in South America, in Africa, in Australia, where typically influenza in particular goes to spread during the summer for us, the winter for them. So the hemispheres flip for respiratory viruses like influenza. We are just now seeing it starting to appear in Africa. So I personally, if I was in Africa or I had family there, would be concerned, because the likelihood is they're going to go into the season where it becomes more of an issue than it has been so far.
Thank you. Dr. Katz, when will antibody testing be widely available?
It's in process now. There are some centers that are doing it and can get rapid testing and get the antibody testing within hours. Not everyone has that yet. It's generally the big university hospitals that have it. Some community hospitals are trying to get it and don't have it. So, I'm not one of the developers of those kinds of testing. All I can say is I hope it comes soon. It can't come soon enough. And I know with every passing week, we're able to shorten the duration of time between when someone wants to be tested and someone is tested and when we get the results. So, I will leave it to the manufacturers to answer that question more scientifically than I would.
Dr. Katz, don't go too far. Stay on the hot seat for this one. One of our friends asks, we are stuck in California. When might it be safe to either get on a plane or in a car to get back to DC?
So, that's going to be a matter of personal risk, I think, and how risk averse one is. So one of my closest friends just went to see their brand new grandchild, and they drove to Denver because they did not want to risk being on an airplane. However, I know many other people who've flown across country, and they may be the only people on the plane, or there's enough social distancing. So I would say that if you wear a mask and you socially distance yourself from others, and you've not been exposed to anyone in the last several days or last 14 days, I do think it's safe for you to come, both for your safety and to not infect anyone else. So it's a very good question. It's very difficult. And, you know, that's like everything we do. Is it safe to go to the grocery store? Is it, you know, the most common question I get. And the answer is mostly safe, yes, but you have to be careful. You have to know what to do. When you're on the plane, you want to wipe down the seat. You want to wipe down the back of the tray table. You want to wipe down the front of the tray table and the armrests, just to be sure. But the airlines are, from what I can read, and I'm not an expert on this, what I read are some of the larger airlines are fogging the planes every night with hydrogen peroxide, which is a very effective antiviral agent to kill the virus on the planes, and it's non-toxic and doesn't destroy their material. And so you could easily get on the plane the next morning and know that it's pretty safe.
Thank you very much, Dr. Katz. Still on the what's happening in diagnostic side before we get into treatment. Are there studies, this will be for Dr. Magnus, are there studies coming out of any places that had good testing that therefore give us reliable ratios of those infected to those with symptoms, to those hospitalized, to those who have passed? Dr. Magnus.
That's another great question. In fact, I didn't have time to go into it, but it's a real issue in terms of the surveillance data that populate our models or our understanding of the epidemiologic curve. There are very different reporting mechanisms. Some of the mechanisms that are reporting are hospital-based data, some are ICD-9 code data or data taken from billing. We have a variety of different types of data that go into those reports, some of the death reports and so forth. So there's not a great system. Most of this test results go through the state health departments or the local health departments, the state health departments, and then some of the CDC data are not even being published anymore. And it depends. There are so many different sites. So I wouldn't say they're perfectly reliable reports simply because we don't have a perfectly reliable system. So yeah, I think at this point we don't have that. Now, in terms of just where we're going to take that in terms of, you know, how we see how many people, the ratio of living cases to deaths or hospitalizations and so forth, that's partially why those uncertainty ranges are so big, because we don't have perfect data and we don't know all the potential error or sources of noise that can interfere with our understanding. So at this point, that's why it's good to look at a lot of different sources. The closer to the source, the closer to the local area that you can capture, the better. So I look at state data, for example, in Virginia. The state health department is reporting number of tests given, number of hospitalizations, number of deaths, and number of cases that have been tested. But that won't tell you the number of people who are infected who have not been tested. I hope that is helpful.
Very, very helpful. Dr. Magnus, to keep you in the hot seat just for a moment, something related question. It says, is there any protocol in the DMV, that is the District, Maryland, Virginia, for doctors or even individuals reporting symptoms to public health authorities for people who have not been tested? The question, is there a way to report symptoms?
So I'm going to say a qualified, I don't know. I think that there is a data set through the the DC Department of Health at DC the District of Columbia Department of Health. I think that they are collecting self-reported data of symptoms. And I think there are a lot of apps out. I know there's some from England, there's some from NIT, where people can report symptomatology that's not been tested and then add into that geolocator data from their phones if they're interested in participating, that actually will say whether they are having symptoms or not and whether they've been tested. But those symptoms are very either sort of commercial through apps, or they're maybe through departments of health. You can look online. I'll look into that to see, and I can send that through this channel if it's if I find out something different. But that's my understanding. One of my colleagues here might know other sources, but not that I know of. I think the reportable data is the testing data.
Thank you very much. We've been taking it too easy on Dr. McKinney for the last 4 minutes or so. So let's throw a couple of questions at him. The first question is, if using a homemade mask, does it help to add a filter such as a vacuum cleaner or coffee filter to the inside of whatever the material in the mask is? Dr. McKinney.
Oh, I would have given that to Dr. Katz. The one thing to worry about with the filters from the vacuum cleaner is, in fact, they have glass fibers in them. And so they may not be an ideal thing to use. Things like the shop cloths are probably a perfectly reasonable material to use for the filters. But at least one website I've seen suggested that the HEPA filters on a vacuum cleaner might be a concern because of the glass fibers.
Thank you. And to answer your question, your implied question, Dr. McKinney, the reason I'm leaning on you is that Dr. Katz is a close friend of the rabbis. I don't want to get on the rabbis' wrong side by working with Dr. Katz too much. I have too much at stake with the rabbis' goodwill. Okay, the next one is going to go to Dr. Katz. Why did the US not use the testing from other countries or from the World Health Organization?
So I actually think Dr. McKinney answered that pretty well. I think the US thought they had the right kind of testing and thought that they would be able to mobilize that fairly quickly. And because of the errors in the design or the manufacturer, we're not able to. And I think it took them probably a little longer than we all would have liked for them to realize that and to figure out what else to do with it. You know, I want to believe that it was just an error and not anything malicious. So, and the idea of what was done in the other countries often is a good thing. We utilize that, but when we have something homegrown, I think that's generally the way we try to do that in this country.
Thank you very much, Dr. Katz. Someone asks, does it help to have had the pneumonia vaccine? I'll take this one. If you're of the right age, you should get pneumonia vaccine. I've gotten it because I'm at the right age. And it's important for all kinds of reasons. But the pneumonia vaccine, as we commonly call it, is not a vaccine against coronavirus. It's a vaccine against some other things, bacteria. And so it's very important to get the pneumonia vaccine and to stay healthier because of that. But it's not a vaccine against the coronavirus. Now, moving on to a little bit more about therapeutic things. Bear with me for just a moment as I scroll through this. This is slightly preventive and not therapeutic. I'm going to ask Dr. McKinney to answer this one, please. How will we determine the long-term efficacy of a vaccine? Will such a vaccine need updating and be only partially effective, as with the flu vaccine? Dr. McKinney?
And the answer is, we don't know because we don't have it yet. Our hope is the catch with flu is that it mutates every year, that you get, it's a segmented virus, and it takes bits and pieces from other strains, combines them, creates a new strain, and changes. And sometimes there are mutations within the various pieces of the segmented virus. So influenza is constantly mutating. So far, the SARS-CoV-2 has been a very stable virus, relatively little in the way of mutation, and particularly in its surface markers that we'd probably be building our vaccines to. So we don't know. We don't have a vaccine yet. We don't know how long the immunity will last, but it at least has the promise of being a virus that looks like it will be relatively easy to build a vaccine to, and that vaccine will be effective because of its the simplicity of how the virus's biology works.
Thank you very much, Dr. McKinney. This one will go to Dr. Magnus. Do we know enough about the virus to say that by summer we can lift the current stay at home to flatten the curve? Dr. Magnus.
I would have to echo the previous answer in that we just don't know. I think that the data are not clear yet. We have not reached the peak by most estimations. I think we just have to wait and see. We just couldn't say that currently, unless others disagree. I don't think we can say that at this point. I think we just need to get closer to the peaks and go through the summer, keep flattening the curve, keep social distancing, washing your hands, and then we should have more information that will help us. I do want to add one thing, if it's okay with you, about the mask situation. I was at the market doing essential marketing the other day, and I was quite alarmed to see that people with their homegrown masks and wearing gloves use it as an opportunity to fuss around with their face quite a lot. So I just want to remind people that if you're wearing a homegrown mask, that might help you it might prevent you from transmitting the disease in particular. It's not a suit of armor. And if you are going up and down with your mask, and if you're putting your hands in your T-zone that Dr. Katz mentioned, and if you've got gloves on, but you're touching everything, these things not only won't help you, they could make it worse. So please just remember, if you're wearing masks, to do that. So that again will help flatten the curve. And so maybe those estimations could be lifted, those restrictions. But again, going back to your original question, I don't think we know that yet, unless others disagree.
All right, thank you. Thank you very much. They don't dare disagree, so they're just going to behave themselves. Now, here's a really tough one. And I'm going to toss this one to Dr. McKinney because I've heard him intone on this before. Look at the look on his face. How much attention should be paid to boxes or bags delivered to our doorstep? Dr. McKinney.
I find it relatively unlikely that you will get infected from a box or a bag delivered to your doorstep. For that to be contagious, so we saw that cardboard, was one of those where it could be, a day's worth of hanging out. But the virus, you don't do what they did in the laboratory test. If you pick up the thing, it's going onto your skin. The skin's still not infectious. If you picked up the paper bag and chewed on it, or if you picked up the paper bag and licked it, you would put yourself at some risk. But most of us don't chew our paper bags, and most of us don't lick them. And so I don't personally find the likelihood that you're going to be able to transfer enough virus from the surface of that paper bag to your mouth. It's a fairly low probability, and you really have to work at it, and most of us don't. So I don't really panic about the paper bags. And if you want to be cautious after you handle the paper bag, before you start eating, you use your Purell or wash your hands.
Thank you, Dr. McKinney. This will be very helpful to my home life because my wife is listening right now in another room, and this gives me carte blanche to order ice cream later this evening when the event is over. Now, Dr. Katz, I have one for you, sort of a charged question. Dr. Katz, the question is, I thought there was a French study of hydroxychloroquine that was promising. So Dr. Katz, could you not only comment on that, but comment on the whole brouhaha about hydroxychloroquine? Thank you.
So I am not an expert on hydroxychloroquine, but I know it has proven uses that are FDA approved. And I know there's a whole group of people who feel that it should be widely used. After all, what do we have to lose? The problem with hydroxychloroquine is that it's a very toxic drug. A number of people have already taken it on their own and have died from it. The safety ratio of the drug of volume to death is very low. So it's very likely you could overdose if you're not careful, if you're using it for non-approved indications. The French study was very small. It was involved very few people and did not have, the patients, as I recall, did not have severe disease. So it's hard to know if it really made a difference for them or not. Now, I've seen that study, but I haven't studied it to know it in great detail. But I do know from talking with all my colleagues who are on pharmacy and therapeutics committees around the country is that they're not going to allow indiscriminate use of that drug, at least in the academic centers. The state of California has issued a warning to physicians to not use that drug for unapproved indications, which is very different than we're usually allowed to do. We're usually allowed to use our medical judgment to use medications, even though they're not specific indications by the FDA. But I think people are very worried about this drug, and that it will give either people a false sense of security that they're getting some result from it, or that it is totally, or it's going to cause significant side effects, probably even greater than the disease itself.
Thanks very much, Dr. Katz. The only thing I'll add to that as a cardiologist is that there are some very profound cardiac rhythm issues that can occur in some people with who take hydroxychloroquine or drugs in that area. This one will go to you, Dr. Katz, because it was linked in some ways to that wonderful demo you did of the different kinds of protective areas. One of our friends says that I've heard something about the importance of covering one's hair and have observed some of that while out in public. Any comments on the importance of covering hair?
Just today, one of our staff members asked about that and covering your feet with shoe covers. There's no evidence to suggest that either of those are necessary. There's no evidence to suggest that there's transmission via that route, someone touching someone's hair or getting sprayed onto your hair. It's like the hair is like the skin. It's not an organ that will allow absorption. Obviously, one should wash their face and their hair if you feel that it's been spread to you. but there's no good science about covering your hair at all.
Okay, thank you very much. Now I have a question for Dr. Magnus, please. And the question is, short of a vaccine, is there any anticipation that eventually, when the curve has been flattened in the longer run, like over the next year or two, is there any anticipation that almost all of us will have acquired the infection? Dr. Magnus.
So my understanding is that, first of all, it would be impossible to know that right now. We don't have adequate testing on the population level, so it's really impossible to say that. It could happen, and I think currently we have both diagnostic testing in place, and that's how you might be tested if you went to a testing site, if you were symptomatic. The antibody tests that have just been approved would potentially help us know if someone's been exposed or had the disease and developed antibodies against it. So you could make a case that downstream we'd have tools to help us identify whether people on the population level had it already. Although we don't know what will happen. The big concern I could see is that there could be another wave that could happen. We stop sheltering at home and we come back, and then we've actually have insufficient herd immunity. Herd immunity would be expected to be seen when enough people in the population are not susceptible anymore for whatever reason. And if we think we have herd immunity, but we don't, we could have another wave that just spike again. Similarly, we don't understand the full characterization of immunity and how long it would last. I think SARS, someone can correct me, but I think the data suggested that there's sort of durable antibodies for at least 3 years post-SARS, something around there, some waning antibody after that, but we don't really know how long that would be. So it's hard to know. That we wouldn't want to say anything too soon because the data are just still coming in. I would defer to the physician colleagues here to chime in on that, but that's my understanding.
Well, thank you. We've come to have touched basically all the questions in the chat, and the time is perfect because the rabbi has some things to share with us as well as one more item. So I want to first start by thanking very, very sincerely and profoundly Drs. McKinney, Katz, and Magnus, not only for their generosity of spirit in doing this, but for the wonderful expertise that they've shared with us. And as I mentioned in the beginning, our best weapon against uncertainty, let alone panic, is to have good information. And I would say that these three panelists have done just a fantastic job of sharing good, reliable information. It's a great privilege to do this. And Rabbi, on behalf of the whole panel, thank you for allowing us to participate in this way. And now back to Rabbi Zemel.
Yes. First of all, Deborah, thank you for reminding me to unmute. And thank you to all of you, David and Ross and Manya and Richard. Thank you all so much for taking the time and sharing your expertise in such a generous way. I'm going to be brave and bold and go out on a limb and ask another question. As this goes on, perhaps sometimes a couple of months from now in June, might you all be willing to regather and do this again for our Micah community as we have more data and as we're approaching the summer? Could we again take advantage of your expertise and your generosity? Is that okay? Putting you on the spot in public, I know is very unfair. Well, I'm getting very good. Okay, thank you all so much. As we are on the eve of our holiday season, I want to wish all of you a great, wonderful and safe Passover, as well as to all of Temple Micah. And I'm going to turn things over to my very dear friend and colleague, Deborah, and say what I love to say to Deborah all the time. Okay, Deborah, use your beautiful voice and your beautiful instrument and take us home.
Thanks, Danny. I'd love to sing this song, words written by a friend of mine quite a while ago, but that I am finding more and more relevant as we together are working to slow this spread. So if you're at home, I'll invite you to sing along if I can get it to move. We need your ears to heed the call. We need your light to shine through it all. We need your hands to hold the line, to hold the line. We need your heart To find the good, we need the will. To do what we should, we need your strength. To hold the line, to hold the line. 'Cause we need your voice to tell our tale. We need your fire to blaze the trail. We need your love to hold the line, to hold the line. We need a peace that lasts the night. We need to stand for what is right. We need a song to hold the line, to hold the line. And I'll tell a brief story before we continue. Earlier today in a worship team meeting, maybe it was yesterday, Rabbi Zemmel asked if this song might be intending not our collective, but to be looking to a capital U, your, and what it might look like to see kind of an ultimate you as the source for some of this strength. So we'll do one verse like that with capital Y, you, and I'll invite you again to sing along at home. We need your ears to heed the call. We need your light to shine through it all. We need your hands to hold the line, to hold the line. We need your heart to find the good. We need the will to do what we should. We need your strength to hold the line, to hold the line.
Deborah, thank you so much. Good evening to all of you. Chag Sameach. Have a joyful and safe Passover.